Hello.
Hello, how's it going?
Good. How are you doing?
Good, good.
We'll just give everybody else a minute or two here. All right. Well, I guess I'll just go ahead and start by talking about this makeup class that I was thinking about having. I actually changed my mind about that. I think it's not really fair to ask y'all to show up to class that we didn't, have scheduled. So instead of having a makeup class or doing anything like that, I think what I'll probably end up doing is we'll probably end up just taking some material off the end of the course. So instead of spending a whole day talking about international comparisons, I'll probably just talk about it for maybe 10 or 15 minutes, and just very briefly cover the international comparisons chapter. So I think that that's what we'll do instead. So don't worry about trying to attend a class on Friday or anything like that. So we'll just chop off a little bit of material at the end of the class. So and I'll put out an announcement reminding you that we're not doing any sort of makeup, so that anyone that's not with us also knows, and you will be reminded. But anyway, um, so let's see. This is where we left off, I believe. If I'm wrong about that, let me know. But I think this is where we left off, right? Okay, cool. Yeah, so today, hopefully we'll wrap up this chapter, but today we will be looking at the different types of evidence regarding productivity, right? The transformation of medical care into health. And we're going to start by looking at some aggregate studies, right? And then after that, we'll look at some randomized control trials, and then look at evidence on productivity of specific treatments, which also turn out to be, some of them turn out to be RCTs, some are not, but and then we'll look at some more finely grained outcome measures as well. All right, so first of all, looking at these aggregate studies, really the question that they're trying to answer is how much do we get from current patterns of medical care use? We being the United States, right? So there's kind of two different answers to this question. The first is what's the productivity on average? What's the average productivity? Turns out that there's a lot of average productivity. There's a high degree of average productivity in the U.S. But the second sort of way to think about that question is on the margin. And as it turns out, it looks like the marginal productivity may not be that high. Okay, so while we are getting a lot on average out of medical care, it seems like we're kind of pushing the limit. We're not getting a lot on the margin, right? That additional bit of healthcare is not producing that much health. But we are very productive on the average, from an average point of view, right? And to be aware of this, this is not paradoxical, right? We talked about the difference between average productivity and marginal productivity. These things can go hand in hand, right? Um, it's not a paradox, right? So just be aware of that. So just so that we're aware, the way that most of these studies are aggregated, we're typically comparing health status of either countries. So sometimes we look at different countries and we're aggregating on the country level. Some of these studies aggregate on the state level, so comparing two states within the United States, and some of them aggregate on the county level, rather. Um, so maybe looking within a state, different counties within a state, or sometimes different counties on the border of two states. That's a very common way of looking at differences. And then there's also aggregation sometimes on these so-called metropolitan statistical areas, or MSAs, which are kind of like big metropolitan regions like Atlanta or New York or Los Angeles, those sorts of things. Um, so. So because of the nature of these studies, right, we're aggregating lots of data, boiling it down to some simple terms. And so these studies rely on simple measures of health outcomes. So typically, we're looking at life expectancy or mortality rates, um, sometimes age-specific mortality rates, and then some of these studies use infant mortality rates as a measure, um, but we kind of have to be careful with the infant mortality rates because these can be mainly affected by things like overall nutrition or broad public health measures like pollution control. A lot of times infant mortality has more to do with these things rather than specific medical use. And this is particularly true when comparing different countries because of the different quality of environment and quality of life in different countries. So the two more common ones are life expectancy and mortality rates. And pretty much all of these studies that are aggregate studies find that four things move together: per capita education, per capita income, medical care use, and good health outcomes. So pretty much all of these studies universally find that these four things move in the same direction. So that when you find countries with higher educations, they also tend to have higher incomes, higher use of medical care, and higher level of good health outcomes. And it's because all four of these are related to each other and they all affect one another. Which hopefully isn't surprising given what we've talked about so far, particularly what we talked about in chapter 2. We saw, especially education, right? There was a lot of correlation between education and good health outcomes. So if you think about it, right, first we think, okay, let's think about income. Well, income can directly affect good health outcomes simply because people with more money uh, have a better quality of life in terms of the environment they live in, right? Richer countries have less pollution. Richer people live in areas with less pollution, things like that, things that directly affect better health outcomes, right? Because they can afford a higher standard of living, basically, right? But it's also true that people with more income can afford more medical care, which itself affects health. Okay, so there's kind of two channels through which income can affect healthcare. Well, more than that, actually, because people with more money can also get better educations. And this has multiple effects. People with higher educations make more money. So here we have sort of an endogenous relationship between income and education, right? They both cause each other. And education itself can provide better health outcomes directly because people with higher education typically make better choices. We saw that in chapter 2, right? Um, whether it's a choice of alcohol use, right? Consuming more wine, which has positive health effects, as opposed to beer and spirits, which have negative health effects. or whether it's just living a healthier lifestyle in general, right? And then there's this further confounding factor, the fact that, right, when you are healthy, you make more money, right? Which in turn allows you to afford more medical care, which allows you to afford better education, which allows you to just live in a place that's healthier, right? Um, and then on top of that, when you're healthier, you can be more productive in terms of receiving a better education, right? Getting an education is easier when you're healthy. So obviously, there's a lot of relationships among these four things, right? And this kind of presents a problem. But before I talk about the problem, um, there so all of these things move together, and that's kind of the uniform findings in all of these studies. But there is one exception that is found in some cross state studies within the U.S., and that is that white males experience higher mortality with higher income. So this is the one exception to all of these things moving together, and the exception is found among white males in the U.S. So why might white males that make more money um, die at a higher rate than other genders and races? Like, what could be the explanation, right? Like, why? Anybody have a hypothesis? Maybe this will help you. So maybe white men that make more money are buying more what? Or consuming more what? Maybe they're consuming more things that are bad for their health, right? Smoking more, drinking more, partying more, right? And you can kind of, I don't know. Um, this is just a hypothesis. We're not talking about any kind of evidence here. But it could be that for whatever reason, when white men make more money, they purchase and consume things that are bad for their health more so than other types of people. I don't know. All right. So now to the complication that exists here. So unfortunately, and this is true of pretty much any sort of aggregate study, any study that looks at things on aggregates, right, adding things up, loses information. There's a loss of information when you just pile things into broad categories. And on top of that, it makes it, because of this loss of information, it makes it really difficult to sort of unravel the true effects of medical care on health, right? Because we don't just have this one relationship between medical care and health. We have income affecting medical care, which also affects health. Income also affects education, and education affects income. You have all of these different channels of causality, and so with aggregate studies, it's almost impossible. It basically is impossible to like dig into the actual true effects, whether it's looking at a single country over time or looking at different countries within the same time period. Okay, so really, like, what's going on here, the most common approach here is looking at the reported spending on a particular medical care treatment, I guess. And one difficulty is that if you're making a comparison across different countries, of course these statistics are given in the country's own currency. So you then have to convert them to some common currency, typically US dollars. And then that brings up the question, well, are we using appropriate exchange rates? What about purchasing power parity? Do we need to account for that? And on top of that, countries have different ways of paying doctors and counting up costs. So at best, this type of study gives us only a fuzzy estimate of the medical care that was actually rendered. If we use the same approach within a single country, but over time, well, then there's a different issue, right? Um, we have to account for inflation, right? So we avoid the problem of converting into a common currency. That's not an issue since we're looking at a single country. But of course, we have to adjust for inflation since we're looking at costs and expenditures over time. And typically, this adjustment's done with the medical component of the CPI. But we still have this issue that income, education, medical use, and health outcomes are moving together, right? All of these relationships are sort of intertwined, and it's still pretty difficult to unravel those true effects, the true relationships. All right, so to think about this, there was a study by Hall and Jones. Anybody know who those guys are? That's Hall and Oates, not Hall and Jones. But their basic analysis was to look at data on spending on medical care from 1950 to 2000, and they combined the data on spending with data on life expectancy at birth. So this is an aggregate study. And they estimated the production function for health as measured by life expectancy. So the proxy or the variable that they're using as health is life expectancy, okay? So that was their basic analysis. They also did the same thing, but they broke it down by age. So they looked at life expectancy by age, and they basically used 20 age brackets going from the youngest bracket being age 0 to 5, and then all the way up to the bracket 96 to 100. And they tied the age-specific life expectancy to age-specific medical care spending. And basically what they were able to do was produce estimates of an elasticity, which they called health elasticity of medical spending, which is basically a measure of marginal productivity. Okay. So here we go. Here are the elasticities for the different age groups. And it looks like they bunched the last several brackets together. They actually did that with several, right? So they did this with 20 different age brackets, but they kind of condensed it. It looks like there's maybe 10 or so here. Okay, so what we see here, right, are the elasticities. Okay, so they're very high for younger people, and then there's sort of an interesting relationship that's discontinuous here once we get above age 15. So first of all, let's just think about how we interpret this elasticity. Okay, so what it's telling us is it's telling us the percent increase in health, which is measured in this case by life expectancy, given a 1% increase in medical care spending. So this would be the formula here. I want you to focus on the first part. That's really all you need to know, right? So this looks familiar, right? This looks like a normal elasticity, like you should have seen, hopefully, price elasticity of demand, right? Which gives you the percent change in quantity demanded given a percent change in price. So here we have something very similar, only in this case, it's what is the effect of health given a certain amount of medical care, given an increase or decrease in medical care. So you could think of this like if you look at the lowest age group, 0 to 5, the elasticity is 0.4. So how do we interpret that? What does 0.4 mean? It means that if we increase medical spending by 10%, then life expectancy will increase by 4%, right? 0.4 times 10 is 4%. So that's how we interpret that, right? If we have someone that's in this age group 0 to 5 and we increase medical spending by 10%, then on average, we should expect their life expectancy to increase by 4%. Okay. So obviously, all of these are positive. I guess it could technically be negative, but we see positive numbers, which means that spending more money increases life expectancy, albeit at different rates depending on age, right? So we see that spending is very effective, right? The marginal productivity is very effective for young people below age 15, 15 and younger. So this is a good use of medical spending in this in this age range, right? It's very effective. But then suddenly it drops off for this age group 16 to 25. So anybody think of why that might be? What were the main causes of death for young people in this age range, if you can recall back to chapter 2? Was it things like heart attacks and liver failure, or was it something else?
Wasn't it like violent stuff?
Yes, that's exactly right. So, young people are typically dying of like accidents or homicides, right? And so, think like car crashes and gunshot wounds. These things are very expensive to treat, right? So that's basically why we see such a huge dip in the productivity of medical spending for these age ranges, early, young adults, basically. It's because of the nature, the things that are causing them to die are things like car crashes and gunshot wounds, right? Not things like heart failure or things like that, right? So that's why we see the huge drop off in productivity. But then it starts to trend back up as we get towards middle age, right? So the medical care spending gets more effective, and that's because as we move into middle age, we're dying. People are dying less from car accidents and gunshots, and they're starting to die more from lifestyle health related issues, right? And so the medical care becomes more effective as we move into middle age, but then we see a decline again once we start getting into more elderly people, right? Because these people are getting really old, and it's really hard to treat them and extend their life. It gets more and more expensive to extend their life because they're just getting so old, right? So that's kind of in a nutshell why we see this sort of pattern, right? Um, and if you're curious, I've got the elasticity of health equation down at the bottom there, and I've got in the box kind of the basic concept or formulation of it. If you're curious, the other ones are basically related to calculus, right? So we can calculate this elasticity using calculus if we want. And so if you know anything about calculus, you might recognize some of those things, right? So the middle one is the amount of medical care spending divided by the level of health, which in this case is life expectancy, times the partial derivative of um, basically the healthcare production function, right? With respect to medical care. So that's what the second and third ones are telling us, basically. Um, okay. And then this is from the same study, just some different information, kind of looking at the same data in a different way. So the top chart is the cost per life saved. Okay, so that's an interesting kind of way to look at things, right? How much does it cost to save a life? And we're looking at it again in the different age brackets, but also at different periods in time. So the darkest bar is for 1950, the middle gray color is 1980, and then the lightest gray is 2000. So a couple of things really stick out here. First, we see that the cost of saving a life is highest for these sort of young adults, teens and young adults, right? And again, that's the same pattern we saw in the previous graph. It has to do with the fact that these people are dying from car accidents and gunshot wounds, right? And those are really expensive things to treat. So it's very expensive to save those lives because of the way that they're dying. And then, of course, as people get older, they're dying from more age-related things and lifestyle health-related things, which are a little bit less costly, more cost-effective, right? Um, so that's one thing to notice. The other thing to notice is the difference, the change over time, right? So, and keep in mind, these are inflation adjusted already, right? So there's no inflation here, right? These are all in constant 2010 dollars. So the huge increases over time is not reflecting inflation, okay? But what it is reflecting mainly is technological change, right? In the year 2000, we had way better technologies, um, which typically are expensive technologies, right? And so that's really what's being reflected here. The huge increase in cost over time among all age groups is primarily coming from technological change. Okay, so that's an interesting way to look at the same data. Another interesting way to look at it is cost per life year saved. So this is kind of an interesting way to look at it, but it's basically combining mortality with life expectancy, right? So you're saving the person, right? You're saving their life, and you're having an effect on their life expectancy. So that's the idea of a life year. Okay, and so this is just another measure of effectiveness, and we see the same pattern, right? The cost effectiveness is pretty low, right? There's a high cost for the young adults and teens. The cost effectiveness improves, right? The cost of saving a life year goes down in middle age, and then it goes back up as we get towards the really elderly end of the spectrum, right? And so the least cost effective spending is in that 90 to 94 age range. Um, you can spend a whole bunch of money saving their life, but you're not going to extend their life by very much when they're 90, 94 years old, right? They're just there's not much you can do there in terms of life expectancy. So okay, let's see. So yeah, so basically what we're seeing here is the marginal cost of saving a life for the top one for chart A, and the bottom one is telling us about the marginal cost per life year saved. So these are all of these are marginal cost estimates. Um, so another interesting thing that the lower chart is telling us about, chart B, is it's telling us it's reflecting society's willingness to pay for another life year. So that's pretty interesting. And Braithwaite et al. In 2008, they made an estimate of the willingness to pay, and their base case estimate ranged between $183,000 and $264,000 per life year. So that's a lot of money, right? We're talking like up to $250,000 just to save someone's life and extend their life by a year. And especially if you compare that to like the average income, average income is somewhere around $60,000 per year. So we're talking like, 4 times that amount, you know. So, it's expensive to save people, but, it's worth it. I guess annual income isn't really the appropriate way to look at it, perhaps, because we really want to think about like lifetime income and things like that. But nevertheless, it's interesting to have sort of an estimate of society's willingness to pay, right? This is basically kind of giving us an idea about the demand curve, right? The demand curve for medical care. All right. Any questions so far? So that's kind of the way that these aggregate studies go about looking at things is in these ways. But obviously, like this is very boiled down, right? This is not giving us a lot of information about things like specific treatments for specific ailments, right? We're looking at healthcare spending on everything, whether it's heart attacks, knee surgeries, all of these things, and looking at the impact of total spending on aggregate measures like life expectancy or mortality, right? So while there's things to learn from these studies, um, there's a lot that we're missing, okay, because of the aggregate nature, right? So to kind of try to get beyond these limitations, we can move into randomized control trials. And so like I've been saying, the aggregate studies suffer from a loss of information. The best we can do is really say that a lot of variables of interest move together, right? Income and education move with medical care spending and health outcomes. It makes it impossible to determine the causes of improved health. And so what we really need is some exogenous variation, right? We need something that's in no way related to these four things to to sort of create a splash and ripple effects so that we can see what are the actual causes of these related things. Thus, randomized control trials, right? So one source of exogenous variation is randomness. Randomize who gets what, right? Since it's random, it's in no way related to income or education or medical care use. And so we can start to tease out the effects of all of these things, right? What are each of those arrows in that diagram I have? What are the specific impacts of each of those, right? We can't do that with aggregate studies. So one of the first, or at least one of the most important and first studies that did this was the RAND health insurance study, sometimes called the RAND-HIS. And so this was started in the early 1970s, and it was federally funded, right? So the National Institutes of Health funded this study. And this is also when we saw the federal funding of medical research start to spike, right? It was in the 1970s, and it was largely in part due to this study here. And the study had two major goals. Its first goal was to look at the relationship between insurance coverage and healthcare use, right? So how, if we change the amount of insurance coverage, how does that affect, or how does that translate into medical care or healthcare use, right? What is the relationship there? And then sort of the second goal was to discover the effects of medical care use on health outcomes, if any, right? Okay, so these were the two main objectives. So just some details about how it was conducted. So it took place in 4 cities and 2 rural areas. The data encompassed over 20,000 person years of data. Okay, so a good amount of data. And subjects were randomly enrolled in either a 3-year study period or a 5-year study period. And they were randomly assigned to various insurance plans. So some people received full coverage, which means that they didn't have to pay anything. There was no copay. It included dental and vision. And so basically, right, what Bernie would like for us all to have: free healthcare. You don't pay anything, right? Except for, obviously there's going to be an increase in taxes if we go with Bernie's plan. But aside from that, right, you go to the doctor, you don't pay anything. And then other people were randomly assigned to what's sometimes called the low coverage treatment with varying co-payments, right? So different levels of co-payment. So I'm just curious, what do you guys think? What were the differences in medical care use between these different groups, do you think? Who do you think used more healthcare?
Probably the full coverage people.
Right, exactly. Just like we would predict, right? So it's interesting because what the study did was randomly varied price of medical care, essentially. So for those with full coverage, the price was 0, right? but those with the low coverage, in the low coverage treatment, they had, you know, to pay some level of copay. Um, and then there was other variation too. I think we're going to look at this study a lot closer when we get to the chapters on insurance, and we'll see like the very specific details there. But for now, just think of it in terms of either full coverage or low coverage. And the study looked at basically three types of different measurements of health outcomes. So the first type was a self-reported um, self-reported data on oh crap, what does ADL stand for? I knew I shouldn't have abbreviated it. Hold on. ADL. Does anybody remember? Did anybody read the chapter and remember what ADL stands for? Here we go. Activities of daily life. There we go. So people were reporting on their ability to participate in activities of daily life, their health status, their mental well-being, as well as some other self-reported measures. And then on top of that, the study also regularly collected data on sick loss days. So basically, you know, if you think about, you know, working 50 weeks out of the year, how many of those days were you unable to work or go to school because of a sickness or an illness, right? So that was one type of measurement that they took, and keep in mind this is self-reported, so it's somewhat unreliable, right? People could be lying, or you know, there could be a number of issues because it's self-reported. It's basically just a survey, and it wasn't incentivized in any way to try to get people to truthfully reveal these things. So you know, we always have to take that type of data with a grain of salt. A little bit more rigorous measurement were basically sort of regular physical examinations, measuring things like weight and blood pressure, vision, cholesterol, hearing, and similar things, right? So this is a bit a bit more objective, right? Not self-reported, but rather a medical professional measuring these things with instruments. So that's good. And then basically the last way to sort of measure this was they took all of these measurements previously mentioned and then used a statistical calculation combining these into what they called health status age, or what we might think of as apparent age, right? Just looking at all these statistics, what's our best guess at your age, right? And so for people that are sick, their apparent age is going to be higher than their actual age. And for people that are relatively healthy, their apparent age is going to be lower than their actual age, right? So I'm 35, but maybe my apparent age is 30, right? I have the average health of a 30-year-old, even though I'm 35, right? That would indicate that I'm in good health relative to my peers. So that's kind of the idea of health status age. All right, so what were the results? So the main finding is not surprising. People that had full coverage used more medical care. In fact, they used about 50% more medical care than the low coverage group. And the disappointing result was that even though people were using more medical care, their health outcomes were basically the same, with two exceptions. And the two exceptions occurred among low-income people. The first exception among low-income people was that low-income people in the full coverage group experienced better corrected vision than their counterparts in the low coverage group, which makes sense, right? Poor people, if they're struggling to put food on the table, they might forego getting an eye exam and getting some glasses or contacts. But if it's fully covered, yeah, I'll go get it. Sure, I don't have to pay for it. Yeah, of course I'll go get glasses. Right? So this seems to make sense, right? The other major difference blood pressure. So this is still for low income groups, right? So income groups in the full coverage group had lower blood pressure, the low coverage, low income group. Okay. Now, the measurement wasn't a lot. It was like 3 millimeters of pressure lower. So it's a relatively, it seems like a relatively low amount, right? It doesn't seem very substantial. But if you dig deeper into those results, you find that the full coverage group had a 10% reduced risk of dying that was mostly attributed to the lower blood pressure. So that's pretty interesting. It seems that this might be an effective way um, to decrease the rate of mortality is through blood pressure treatments. So that it seems like there might be a high marginal productivity here, right? So that's good. But aside from this, there wasn't a lot to be revealed from this study, unfortunately. So, you know, I don't know. It's a little bit bittersweet. There was some good information that came from it, but given the amount of money that was spent, I think that the researchers were hoping for better like a more wide plethora of results rather than just like, well, it doesn't seem to matter much, except for among low income people, right? Which is important. That's an important finding, right? It tells us that things like Medicaid might be really effective, right? And if you don't recall, Medicaid is the government program that gives poor people health insurance. So, so there's some rationale there for it. But there were some issues with this study, okay? It was a relatively short time horizon, right? Only 3 to 5 years. Ideally, we would conduct this study over 10, 20, 30 years. And that would help give us a much better idea. It might strengthen our results quite a bit, but it would also allow us to sort of see how insurance coverage might interact with changes in technology over time, right? That would be a really interesting thing. How if we did this same study today with today's technology, we might have different results, primarily driven by the fact that we have better technology, right? So that would be interesting to see if we could have that study. Another problem was, even though there was, over 20,000 person years of data, the number of subjects was relatively low, only 5,800 subjects. And so there's a question of whether there's enough statistical power here, right? And so maybe the reason that we didn't see a lot of results is simply because there weren't a lot of people in the study. If we were able to increase this to say 60,000 people, maybe we would start to see more results than other than just these low income results that we saw. Another issue is that the study did not detect differences in health habits related to the insurance coverage. So, and maybe this has to do with the short time horizon. This partially could be due to the short time horizon. Maybe if this was done over a period of 10 or 20 years, we might have seen some differences. But apparently, at least according to this study, people with full insurance compared to those with low insurance, they didn't really have any differences in terms of changes in their lifestyle habits, right? Which I don't think is that surprising. Why, well, I mean, maybe it is somewhat surprising, right? We might expect that people that are fully covered, they might smoke more or they might drink more, right? Since they have full coverage, well, hell, I can be, it's called moral hazard, right? Maybe you've heard of moral hazard. When you're fully covered by insurance, you act more recklessly. So, we might have expected that, but apparently that's not evident given the data here. But again, that could be simply because it was such a short time horizon. It could also be related to the lack of statistical power. Both of those things might be impacting this finding. So, but there is a glimmer of hope in this study. They did have enough statistical power to determine the chance that a true effect was not detected, which isn't it's nothing to be like woohoo. But they were able to rule out the possibility of anything beyond a minimal effect on various health measures. So, you know, this was a first go, this was like a first attempt. So, it did provide us with some interesting results, things that we do care about, but, it kind of left researchers, wanting more, I really would like to know more, you know. And so this kind of gave birth to um, studies that were a little bit more specific, looking at specific treatments, right, and the productivity of specific treatments. And most of them stuck with the RCT, right, because this really is the strongest type of study. It provides important and highly reliable evidence because of the randomness, right, the random variation. So these studies on specific treatments they're able to tell us whether an intervention actually improves health outcomes, and it at what cost, right? So this is really useful information. uh, does someone taking baby aspirin help them prevent heart attacks? If it does, great, because baby aspirin is super cheap, right? That's a super cheap treatment. So if it's effective, then great, let's go with it, right? Maybe it's not effective, even though it's cheap. So maybe there's better alternatives that might be more expensive, but they're also more effective, right? So that's kind of the idea here. And a lot of these studies provide important evidence on the types of margins, right? Whether it's intensive or extensive, right? So let's look at table 3 to kind of think about this here. All right, so here are estimated cost effectiveness of commonly used medical interventions. Okay, so we can kind of look at the first one here. Um, Low dose lovastatin, which I think is a drug for high cholesterol. So for the first two groups here, we have male heart attack survivors um, in the age range of 55 to 64, broken into two groups depending on their cholesterol level. So the first group is a group with high cholesterol. The second group is a group with low cholesterol. And you can see that the cost effectiveness is pretty good, right? Um, about $3,000 per life year. That's pretty cost effective, right? Especially when we were talking about earlier with the aggregate studies, we were talking about hundreds of thousands of dollars per life year, right? So $3,000 sounds, wow, that's really cheap, right? Let's go with it. Let's do it. So that's very cost effective, right? You compare that to some other groups, female non-smokers between 35 and 44. This is not a cost effective treatment. $3 million per life year. We can spend our money in better places, right? That's not a cost effective use of this treatment. Okay, so we're thinking about the extensive margin, right? Who do we give this drug to? How many people do we give this drug to? Should we bother giving it to female non-smokers, or even female hypertensive non-smokers, right? A more specific subset of that group of females, right? Slightly improved cost effectiveness there, right? It's only half of expensive to increase someone's life year, but still not very cost effective when comparing it to male heart attack survivors, right? So that's an interesting one. We might look at exercise electrocardiogram as a screening test. Okay, so this is a pretty effective treatment for 40-year-old males, much less effective for 40-year-old females. Okay, so again, we're thinking about the extensive margin. Do we bother giving this treatment or screening to 40-year-old women, or should we give it to more 40-year-old men? This data is telling us, well, give it to more of the men and less to the women, right? That's a more productive margin, is to give it more to the men. Similar finding with hypertension screening, right? It's more effective for men, 40-year-old men, than for 40-year-old women. So all of these are thinking about the extensive margin, right? Not as much of a difference there with the hypertension screening, but still somewhat of a difference there. Okay, and then if we move on to the breast cancer screening, now this one is more about the intensive margin, okay? Because the first category is just a breast examination, whereas the second category is both a breast examination and a mammography. So increasing the intensity or number of treatments for a particular, in this case, breast cancer screening, right? So here we're thinking about the intensive margin more, and here we see that including the mammography is less effective, right? It's more effective to just give breast examinations, right? And so this might be something that we, rather than extend on the intensive margin, we might want to extend on the extensive margin, right? Let's give more breast examinations rather than giving people, in addition to breast examinations, also giving them mammographies, right? It's more cost effective to just give more breast examinations, right? So again, thinking about the intensive margin. Let's see here. Okay, so another one that's about intensive margin is pap smears, right? Giving them every 3 years as opposed to giving every 2 years. Okay, so here's a huge difference, right? So giving a pap smear every 3 years compared to not screening at all, we have a cost effectiveness of $36,000 per life year. And if we just increase the intensity by just a little bit, right, every 2 years instead of every 3 years, the cost effectiveness just blows up, right? $700,000 per life year. Okay, so not cost effective at all. So in this case, don't bother giving women, don't bother increasing the frequency. I'm going to mute my video for a second. My internet's unstable. Right, this data is telling us don't bother upping the screening to 2 years from 3 years. It's not a very cost-effective measure. Instead, it'd be better to find women that aren't getting pap smears and give them a pap smear every 3 years. That's a more effective way of saving life, right? Is finding those women that aren't getting pap smears regularly and provide them with them, whether it's through Medicaid or some other government program, perhaps, right? Let's see. Moving on to coronary artery bypass graft, sometimes called cabbages. So cabbages for left main coronary artery disease, which is a very major part of the heart, as opposed to performing these cabbages for single vessel disease with moderate angina, which is a less severe form of heart disease, basically. So obviously, it's more cost effective to perform these bypass grafts on people that have a very major heart ailment, as opposed to performing them on people with more moderate to less severe heart ailments, right? So again, this is the intensive margin, right? Is it? No, actually, this one is the extensive margin, right? So do we give it to people with the left main coronary artery disease and ignore people with the single vessel disease, or do we include more people? Do we include people with this single vessel disease? So this one's on the extensive margin. And then neonatal intensive care, this is also on the extensive margin. So looking at the effectiveness of neonatal ICU. So this, we're looking at infants at different birth weights, right? So infants at a low but moderate birth weight compared to very low birth weight. So obviously, when you have, this particularly pertains to premature babies, right? That typically have very low birth weight. It's very costly to improve their life expectancy. It's a very, there are a lot of complications with premature births. So that's why we see such a high dollar value for, cost per life year for those very low birth weight babies. But this type of treatment is more effective for babies that have a little bit more weight, so they probably aren't as premature. So that's not surprising, but that one is on the extensive margin, right? So pretty interesting results, right? This is pretty telling. It's very indicative of where medical care spending is most productive, and just within this table, it's most productive in that low dose lovastatin drug, and the physician advice about smoking cessation, a 1% quit rate. Pretty effective, right? But also low cost. Just a doctor saying you should quit smoking, right? But it's effective, right? It's cost effective. So, these are areas that we would like to maybe extend on the extensive margin, right? Because it's so cost effective. Things that we would want to avoid are things like giving that drug for cholesterol to female non-smokers between 35 and 44. That's a waste of money. Giving 40-year-old females exercise electrocardiograms, that's a waste of money to some degree, right? There are better uses of resources. So this is a good way to think about things. This is very useful. It's very informative, right? So these were some of the, this is data from some studies. Let's see, Garber and Phelps, 1997. So, kind of at this point, this is kind of an older study at this point here in 2021. There were some more updated approaches in more recent history. So these newer approaches compare in greater detail the procedures used and their costs to treat specific medical conditions. And one particular aspect is that they're looking at changes in costs and outcomes over time. So that's nice. This study that we looked at here was not over time. So this was kind of a snapshot in time. But these newer studies kind of look at the same sort of information, but over time and in a little bit greater detail. So typically what is done is it's done on a case-by-case basis, right? So a single case, right? One person that has an ailment, what were their treatments? How much did it cost? What were the outcomes for that person, right? So the case-by-case spending is matched with case-by-case changes in outcomes. And the first of this newer approach came from Cutler et al. In 1998. So we're going to look at that data and see what they found. So what they did was they measured changes in cost and outcomes of treating a heart attack. So a very specific ailment. And they looked at the period from 1984 to 1998. So they're tracking this over time, which is nice. And what they found is that over the course of that time period, the cost of treatment increased by about $10,000. And they controlled for inflation, right? So this is inflation adjusted. And the outcome associated with that cost increase was that the life expectancy increased by 1 year. So in other words, what they found was that the cost per life year was $10,000. So pretty effective, right? That's a pretty low cost per life year, especially compared to what we saw in that table. Right? Pretty low. I think the only things that were lower in that table were the cholesterol drug and the advice to quit smoking, right? Something else interesting that they found was that most of the change in both the cost and the outcome were the result of technological change. So just improved technology is driving both the cost increase and the increase in life expectancy. Okay. And so these guys, I mean, basically they set the stage for all kinds of studies, right? Because they just looked at heart attacks. There's so many different ailments you could look at, right? So obviously they spurred a whole body of research that's today is just huge. So basically, lots of researchers basically copied what they did, but looked at different ailments, right? Whether it was like, well, we'll see what, there's all kinds of different ailments that we could look at. So Cutler went on to do another study in the same vein with his colleague Mayara. So they took a similar approach to low birth weight infants. And they looked at a period from 1950 to 1990. So one interesting thing about this is that, there's a huge technological change over this period. It's a 50-year period. And so, given what the previous study found, most of the changes they saw were due to technology. We should expect to see some pretty substantial changes here over a 50-year period. And indeed, that's what they found. They found that the cost of treatment increased by $40,000, and the life expectancy increased by 12 years. These are huge. Well, the 12 years in particular is a huge change, right? We're adding 12 years of life expectancy to these low birth weight infants. That's just a huge number. And if we put that in terms of cost per life year, it's basically, you're basically taking $40,000 divided by 12. So we're talking about $3,333.33 if you want to be that specific, but a pretty low cost per life year, right? This is right in the ballpark of that cholesterol drug for male heart attack survivors. So this is a good place to spend money, right? This is very cost effective. And they found the same thing, right? Most of the change in both cost and outcome resulted from technological change. So just the fact that we have way better technology to take care of these low birth weight infants than they did back in 1950, right? All right. Well, at this pace, we're not going to finish this chapter, so we might have to wrap it up on Monday, but that's okay. Whoops, duplicate slide there. You can ignore that. All right, so that's kind of the nature of these treatment and ailment specific RCTs, right? That's the kind of the approach. So like I said, there's tons of these studies out there looking at different ailments, different treatments. So I mean, we could have an entire semester looking at just those studies. So but you get the idea, and we'll come back to those studies at various points throughout the semester. So, but there is kind of an underlying issue with all of these studies, and that's that they all use basically life expectancy as the measure of health, which means that they're comparing anything that might increase quality of life and life expectancy. And we that, right? Life expectancy isn't the only health measure that we care about. We also care about quality of life. And so to sort of highlight this issue, we can look at a comparison of two international studies that kind of address this quality of life issue. So in case you're unaware, the Canadian healthcare system is a universal healthcare system. And so because of that, they often have to ration a lot of medical treatments, right? Since the price for medical care in Canada is zero, there's essentially a shortage of medical care in many instances. And so a lot of things have to be rationed. And that presents us with somewhat of a sort of what's called a natural experiment. Okay, so it's not a pure experiment like an RCT, right? Nobody's randomly being assigned to Canada or the US, but it does provide sort of a natural experiment. Since the policies in the US and Canada are different, we can look at, we can take that sort of as exogenous variation. So we can look at the marginal value of extra treatments that are used on the US side of the border, imagining that, so imagine you're a Canadian living in Toronto, right, which is not that far from the United States. You could, Buffalo, New York is like an hour and a half drive from Toronto. So maybe you're living in Toronto and you're on a wait list for some medical treatment. Well, one option is to drive across the border to the United States and pay for that treatment yourself out of pocket where you don't have to wait. That's one possibility, right? And then on top of that, you have citizens in the U.S. that aren't on a waiting list, but have other issues that they face, like insurance coverage and things like that. But this type of study focuses on invasive treatment for heart disease, right? This key study focuses on the treatment for heart disease and looked at efficacy through mortality due to heart attack in the two populations, the Canadian population and the U.S. population. And so here were the results. The U.S. population had much more treatment, 5 to 8 times as much treatment in the first 30 days following the heart attack. So a lot more treatment in the U.S., mainly because it's not being rationed and it's not government provided health insurance. Now, the disappointing finding was that there wasn't much of an effect on mortality rate. There was only a slight improvement. So 21.4% mortality versus 22.3% mortality in Canada. So even though, much higher utilization of medical care, there wasn't much of an effect on the mortality outcome, which is indicating that the marginal productivity of the extra treatments is very small, right? So and this is an intensive margin, right? We're talking about the intensive margin here, but the marginal productivity is very small here. But since we're looking at mortality only, we're potentially ignoring very important improvements in health, right? So it might be that people are more or less dying at the same rate, but maybe the people in the U.S. have a higher quality of life because of the additional treatments. And that's actually what this other study found. It showed the importance of measuring other dimensions of health outcomes. So what they found was that, well, first of all, some other details in terms of care. Canadian patients stayed in the hospital a day longer than U.S. patients on average, while U.S. patients were more likely to receive aggressive care, which is kind of what we saw with the 5 to 8 times more treatment level, right? And so here's some outcomes that mortality rates don't tell us. U.S. patients were less likely to have chest pain a year later, and were less likely to have shortness of breath. Okay, so mortality doesn't tell us anything about this, right? So this is something we're missing if we're only looking at life expectancy or mortality rates, right? So measuring mortality misses, other important health gains that we obviously care about. So this of course, this issue led to a whole other branch of research things other than just mortality or life expectancy. Which leads us to a discussion of so-called quality of life adjustments. Right? So rather than just looking at mortality or life expectancy, let's look at those things with an adjustment that accounts for quality of life. Okay, so just to think about this, right? So if we're talking about improvements in the treatment of mental illnesses, we would almost never see the impact of the improvement of those treatments in mortality data, right? Except for maybe in cases of suicide related to mental health, right? But in most mental health illness treatments, we're not going to see an improvement in mortality rates, or we might see to some degree an improvement in life expectancy, but almost certainly not in mortality data. It'd be the same for like knee and hip replacements for the elderly, right? These procedures are not going to change the rate at which these people die, but it is going to have a profound impact on their quality of life. Same thing with medications for pain and nausea, right? These are not treatments that are going to make people live longer or die at a slower rate, but it's going to allow people to live in a higher quality of life, right? So there's two widespread approaches to this type of adjustment. So there's something called quality adjusted life years, or QALYs, as I like to call them. And then there's something similar but substantially different called disability adjusted life years, or DALYs. Okay, so we're going to look at these in detail here. We'll probably only get through the QALYs with the rest of the time we have, but we'll pick up here from at DALYs next time. So basically, this approach uses a ratio of incremental costs to incremental effectiveness, sometimes referred to as ICER. And basically what the ratio is telling us is it's giving us a bang for our buck. Okay, that's kind of the way to think about it, is it's telling us the bang for the buck. So the bigger the number, the better the bang for the buck, the more cost effectiveness it is if the number is bigger. If the number's lower, it's lower, there's a lower cost effectiveness. We're getting less for our dollar. And these measures are widely used in the US and Great Britain. Now, we have to admit that this type of adjustment is relatively complex. It has to be done for each separate health status. So this can be quite a daunting task, which is kind of why there's an alternative, DALYs. But basically, the idea is, we might want to compare 1 year of perfect health with 1 year of living with blindness, right? So if we measure perfect health as 100, it's kind of like an index almost. So if we think of perfect health as being 100, what would the value of a blind year be? Well, a lot of studies use a value of 60, which basically means that living with blindness means that the quality of life is basically 60% of normal perfect health, right? That's how we can think of this, right? So again, the higher the number, the more cost effective the treatment is. So the most rigorous way to go about this is using what's called a standard gamble. And you're basically asking people to choose sort of like lotteries, right? Would you rather have a 50% chance of living without blindness and a 50% chance of having blindness, or would you rather have, X percentages of having these outcomes, right? So basically a lottery choice. So it's very rigorous because it can give us really good estimates of these numbers, but it's pretty. It can be unreliable because when people are responding to these surveys, they have to understand probabilities. And if you have survey respondents that don't understand how probabilities work, then you're not going to get good estimates. So while it's the most rigorous, it kind of hinges on the ability of the survey respondents. So there's a somewhat more intuitive approach that involves something called a time trade-off. So this is easier for people to understand. So it compares, say, 100 days with normal health to N days with a migraine, where N is the time trade-off. Okay, so if N equaled 60, that means that a day with a migraine results in only 60% of the value of full health. Okay, so it's similar to the blindness thing, but this is a more easy way for people to sort of intuitively understand how to respond rather than using probabilities and these complex standard gambles, right? All right, we're pretty much out of time. There's a few more slides on QALYs, but we're out of time, so we'll pick up from here next time. Hopefully, wrap up this chapter in about 20 or 30 minutes on Monday, so that we can get started on the next chapter. Are there any questions before you all go? So if anyone came in late, just be aware that I mentioned in the announcement that we might have a makeup class on Friday. I decided to scrap that plan because I think it's unfair to make you guys, attend a class or watch a recording simply because I wasn't able to hold class on Monday. So rather than having a makeup class, we're probably just going to cut some material off the end of the term and sort of abridge our discussion of the last two chapters essentially. Um, so be aware of that. I'll still make an announcement because I think maybe we're missing one or two people. So I need to make them aware that we're not having a makeup class. But in any case, um, if there are no questions, you all have a good weekend and we'll pick up here on Monday. All right. Bye.